Okay, let's get going then with our panel. As I say, we have a very eminent panel this morning. I suppose a very wide diversity of voices and views across the health services, from patient experience and patient voice to leadership to management to different professions and beyond. So I'm going to do a very quick run through. There's comprehensive bios in your pack. And there's just one change to the lineup today. Our Chief Medical Officer, CMO in the Department of Health, Professor Breda Smith, sends her very sincere apologies that she's not able to attend as planned today. So I suppose I won't say no particular order, but in the order that they are here on my right, Colm Henry, who will be well known to many of you as the HSE's Chief Clinical Officer, in post since 2018. I think we first met on the COVID NEFIT column, but maybe less said about that. Today may be the better. And obviously, Colm, I think, will have a lot to say, and hopefully in response to the international work as well. I know in terms of leading clinical reform, including patient safety, but across many other aspects of our health service. Rachel Kenna is Assistant Secretary in the Department of Health and the Chief Nursing Officer for Ireland. So Rachel looks after the National Patient Safety Office, so she is our boss. But she also has a policy portfolio across professional regulation, strategic workforce planning, which I think is a really important element when we look at patient safety policy and population health screening, among others. So welcome, Rachel. Next on the panel then is Dr. Ronan Glenn, who again will be known to many of you from a former colleague in the Department of Health. So Ronan has, I suppose, a long career, but mainly I think in public service, but also in private, but a lot of it in health practice, both as a doctor of many specialties and a physiotherapist at the start. And Ronan joined EY Ireland as Health Sector Lead in 2022, and I know is doing some very interesting international research on future trends. So again, very interested to hear from Ronan about how that interacts with the future patient safety agenda today. So next beside Ronan then is Katie Verling. So Katie, we met for the first time just this morning, so you are very, very welcome. Katie is here representing Patients for Patient Safety Ireland, which is a World Health Organization. WHO have a network for patients for patient safety in many countries. And that is, I suppose, one of the many organisations in Ireland who for many years have and continue to represent and advocate on behalf of patients on many topics, but including patient safety. So Katie formerly worked in arts management, so I think I'm really looking forward to Katie, and not only from a patient perspective, but also from your own background in terms of the unique perspective that you bring in relation to that, and maybe to talk about your own journey as a patient and how you merged, I suppose, that experience with arts and your award-winning documentary from that. So very welcome, Katie. Beside Katie then is Dr. John Brennan, who anyone who was at the conference last year, I think you were the star of the show in many ways, John. So I still hear people say John Brennan and Britney Spears. So if you were here last year, you know. So, but John is a GP, but also a fellow and a board member of the International Society for Quality and Health Care, known as ISQA, who are, again, a very important international partner for us in Ireland in terms of patient safety. And John is recently back, as I think some delegates here, from the annual conference in Seoul this year. So I know culture was on the agenda there, John, so looking very much forward to hearing a bit more in addition to what Ria spoke of this morning in relation to international perspectives. And then the final person at the end of the panel there is Orla Healy. So Orla is essentially my counterpart in the HSE, working with Colm. Orla is the HSE's National Clinical Director of Quality and Patient Safety. So you've been in the role for 2.5 years, that role, but obviously a very long career in public health and patient safety behind that. So Orla and her team, many of them are here today. The QPS Talk Time that many of you will be familiar with, we're speaking on that, and they're doing some live streaming from the venue today for people who can't be with us and recording that. So that's the team, I suppose, that drives the patient safety strategy in the HSE. So that is our esteemed panel, and I think that's probably enough for me. So I might start and open up the discussion, and maybe for each panel member to maybe open with some reflections on our theme today and maybe what you heard this morning from the various speakers. So, Colm, do you want to kick us off?
Yeah, thank you. So, I'd like to be on this panel joined by, as you put it, so many esteemed people.
Is the sound on the mics up here?
Can you hear me okay?
It is now, thank you.
Can you hear me okay?
Yes.
Yeah. So, I think it's interesting to follow the trajectory of this conference over the years it's been held, that there's a relentless pull, gravitational pull, towards more patient involvement and safety framed around what is important to patients. And if you look at the journey in some of our medical or nursing or health and social care professional lifetimes over the past 10, 20, 30 years, that has been the journey from paternalism to partnership. But in line with that, from a passivity in relation to patient safety, where we reacted to events, where we now hopefully are trying to build capacity for patient safety, because if we wait for bad things to happen, they always will.
Okay, Rachel.
Thanks very much, Kate, and also delighted to be here and have the opportunity to answer some of these questions. So the theme for me forces thinking, I think, in patient safety and all of the good work that we do. The theme is in direct opposition, in my view, to the historical approach that we've taken in managing incidences and reacting to harm, so without first focusing on prevention. So this theme reminds us to focus on the importance of focusing on prevention. I think the tagline, listening, learning and responding, helps us and demonstrates how we can do this by being more proactive in patient safety and our roles in listening to patients and to our staff, what we can learn from them, and most importantly then having responses that are appropriate for us to be able to grow and develop. And I think if I was to break it down into three parts, what I would say is patient safety culture jumps out and the importance of that in the current conversation. People, our workforce and our patients, of course, and engaging with both directly in the context of patient safety, and also then the need to pivot and move our thinking and focus on appreciating what we have achieved, but then using the momentum that we get from that to proactively prevent harm in the future. And we heard a lot of comments and with Ria's presentation about the importance of data and bringing that into the conversation. So that's where I am.
Okay, so some themes I think starting to emerge for our conversation. Ronan?
Thanks, Kate. Yeah, I think for me it's listening, learning and responding, and I think this morning so far the focus has been primarily, understandably, on listening, learning and responding to the public and to patients, but for me we can't achieve this without listening, learning and responding to our workforce as well. If we look internationally, workforce is the single biggest challenge facing healthcare systems as we look to the future, and indeed in the here and now. The WHO earlier this year stated that the crisis in workforce is not something that we need to deal with in the future. It's something that we must contend with today. And I think our workforce, as we seek to get them to keep a continuous eye on patient safety and to continuously improve, we have to be cognizant all of the time of the pressures they're facing as we come out of the pandemic, the backlogs in care that they're dealing with, the rising patient expectations around the experience that people are seeing in every other part of their life as digital transformation takes hold, and then digital transformation itself and whether that's going to be a force for good or ill for our workforce. So I think for me a key part of this conversation is listening, learning and responding to those who ultimately are the ones who are tasked with delivering care.
Okay, thanks for that, Roland. I think you've mentioned a couple of themes that we'll come back to there as well in terms of digital transformation, how that may enable or maybe create new risks that we need new patient safety solutions for. But as you say, all of the work that we're trying to achieve will be done by and with the healthcare workforce. And thanks for kind of mentioning that momentum around the challenge of now. So Katie, any opening reflections from you in terms of the patient perspective? And I know there's a lot around the listening and learning, and Bernard talked about hearing and communication. So some of it struck me is about the stories that we tell each other, isn't it?
I just first of all, I just as a kind of preface, I would like to point out, it occurred to me that there's a huge amount of negativity, particularly in the newspapers and the media generally at the moment, which is creating a national narrative of the Irish healthcare system being overburdened. And, oh my God, there wasn't enough money in the budget. And the implication all the time is that as a result, anybody going into an A&E department or going to their doctor is feeling a level of anxiety already, because we're putting pressure on healthcare professionals, and we're feeling anxious about ourselves. We don't know if we'll be listened to because there's so much pressure on that side. And I think that we have to be really careful. I know we have to report, and we have to have open disclosure. We have to report when things are going wrong. But I used to work I was working as an arts centre, running an arts centre. And so I was in the culture sector and enjoying it, stressed out of my mind, but enjoying it. And I suddenly felt ill, went to hospital. The following morning, a very nice consultant came up and took my hand. And I have to use bad language here, but you'll understand the context. I have to say, if a consultant takes your hand very gently, you're fucked. And I was told that I had leukemia. But I can tell you, and that was 16, 17 years ago, I can tell you, I was dead lucky. I had a fantastic care, absolutely brilliant care. At that time, I was a private patient. Now I'm retired. I don't have the money for it. And I have been treated as a public patient throughout. I've had superb care, and as a result of having this history of leukemia and all sorts of other bloody things, I'm always taken seriously. Always. I will refer to this again, because I don't know how many of you saw the Orla Tinsley article in yesterday's Irish Times. Mm-hmm. And one thing that I will be talking about is the importance that I thought that because I could speak well and that I knew the health system, I would be able to advocate for myself. And that doesn't always happen. And so I was speaking to a really interesting man out there in the foyer, and who's a nurse, and he said to me, the most important thing we can do in what we do is expect to deliver a service that we would like to have delivered to ourselves. So each one of us here is a patient. You're not just healthcare professionals. You're not just HSE administrators or whatever. Each one of you is a patient, or you've advocated for your children or for your parents or whatever. So all of us have experience of the healthcare system, and we all want a system that will be as good to us as we would like it to be.
Okay, well, thank you, Katie. That's a new tip for me. The next consultants I meet, I'll be standing 3 feet away from them. Keep my hands in my pockets. Yeah, that's the tip. But no, thank you for that. And I think part of the challenge that we'd like to talk about is there's a sense, and very much in the room, that's what we want to achieve. And then the tools that we have to achieve that are not perfect. It's strategy, it's work plans, it's Gantt charts, it's data. So I suppose that's the challenge for us, how we connect that human with I suppose our professional responsibilities, but also our professional aspirations as well. So thank you. John, some opening reflections from you.
Yeah, thanks, Kate. It's lovely to be here again this year, and I'm very humbled to be up on this stage with such incredible expertise out there in the room about this theme. I suppose when I started singing Britney Spears last year, I didn't actually expect to be hit one more time, but here we are. I suppose a few pieces of this theme I think it's worth taking a second to unpick and reflect upon. First of all, I think that first word, nurture, is a wonderful one to describe what we're here to do today. Because there are seeds all over the country germinating around patient safety and patient safety culture all of the time. And they're germinating in the face of incredible challenges, as have already been alluded to. And those little saplings need to be looked after they need to be cared for, and they need to be given, the resources to grow and to bear fruit if we want to really improve patient safety and patient safety culture. The second word then I wanted to kind of pick up on was listening. And for me, I think it's really important to acknowledge that, we can listen all day, but if we have not created the space for the people we need to listen to give us the information that we need to create safer care, then it's going to be a waste of time. So I think there's something that comes before listening in opening up this psychologically safe space for every patient and every professional to be able to talk about safety when things go not so well, and then when things go well too. And that brings me on then to that last word, responding. I think if we're in response mode all the time, then we're probably missing a trick. I think we need to try and get from reactive to proactive and more generative in terms of how we think about safety. We can learn absolutely from the things that we find and need to fix, usually the things that have not gone right. But I also think we need to spend a lot more time learning about the 90% of the time things are going really well. And as a healthcare workforce and a system, we are finding ways to create safe care all of the time. I think there's a lot of learning there too.
Very good, and I think that's what's often referred to as the patient safety 2 kind of agenda, and I know, Colm, you referenced this as well as in relation to, and Rachel, how do we now move to being proactive? And some of that is, do we have the space and the time from pressures, but also the psychologically safe space to actually look and see how do we harness all of this information, this experience, and then have some control over how we build the new, that we're not constantly responding to pressures or crisis, or that to have some structure on it. Or there's some opening reflections from you?
Yeah, my reflection is being sixth on the panel means you've got to think of something different. Says the obvious things as we go along. What strikes me is how far we've come. Over 25 years of patient safety science, building a culture of patient safety in 2008. And as I sit at this conference today, I think that the theme of this conference dovetails so nicely with the conferences that have happened in the last month. If I look at the patient engagement conference, if I look at our own Just Culture conference, or if I think about the launch of the simulation office last week, how far we've come in building a safety culture in this country, and how we've developed the tools and the building blocks required to enable that culture. Having said all of that and having done all of that, I am struck at how we continually need to listen to patients, listen to the workforce, listen to our international colleagues, and learn from all of that experience. And while we could say we can do a variation, or theme and variations here now, is responding to events when things go wrong, or is responding, I'm going to take the approach, it's responding to this agile healthcare environment and this constant change. So we've got slow into care, we've got that left shift, that brings huge opportunities. It has to happen, but with it come risks and new safety challenges. So we are constantly evolving, listening, learning, responding. And it's our role in the operational service delivery side to provide people with the tools within the health service to do that.
Yeah, that's really good, I suppose, to mention that, because, Colm, coming back to you, I suppose, and we've talked about, and Ronan has mentioned, as well as Rachel, like the workforce. So when we talk about the HSE and reforming and moving to new structures and regions, it's really the people in the HSE. I heard a very nice quote from you, I suppose, for one of your other, focus of older people, that older people are not the problem of the health service, but the purpose. And I wonder, just reframing some of the challenges in patient safety. The patient safety isn't the problem; it's part of the purpose, or adherent to the purpose of what we're doing. So, as you're kind of looking ahead now to the big, it's a big reform, moving to the structures and where we're moving to, and listen to RIA and other countries as we're grappling, like reframing some of our challenges through a patient safety lens. Does that make things more challenging? How do we enable the workforce to meet all of that and to continually learn and improve?
Yes, and just first, Katie, thank you for the prompt. I'd be very careful how I shake hands with people from now on, or how robustly I shake hands. But if you look at, again, the journey of patient safety in these conferences, we've moved through capacity building, capability building, all the expertise in this room from somewhat niche and programmatic approach, for example, sepsis, AMRIC, I see Emer Brannigan here, early warnings course, good to see Aveline Casey back down in the audience who led out in that for so many years. But why, when you see the earlier talk, linking safety to outcomes, why don't we operate on a broader canvas? For so long we've defined access to unscheduled care, for example, on trolleys. Trolleys are things, they're metal objects on that are counted in the morning, and there's a dispute over how they're counted. Then we began to talk about patient experience times. But now we need to redefine that in terms of harm, and that's what we're trying to do this year. We know from studies in the UK, for example, for every 82 people waiting over 6 hours for admission, there's one additional death. We also know of individual cases where harm is done. And we all know the old adage that no one sets out to do harm in the morning. But what we're trying to do now is reframe the unscheduled access problem, trolleys, into patient experience and safety. Hence the focus particularly on older people. We were doing our roadshow for this year's and the 3-year plan for unscheduled care, and 1 or 2 people stood up everywhere we went protesting, I'm not trained in older people, it's not my business. It's everybody's business unless you're a paediatrician or neonatologist. It's everyone's business. We don't pick the patients who come to our care. So what we're trying to do now is harness, if you like, the power of the patient safety narrative and its ability to change people's behaviour and culture and apply that to the biggest challenges in healthcare, access to outpatients. It's unsafe to wait for months, if not years, for outpatients appointment. And certainly on scheduled care, we know it's very unsafe for older people to languish on trolleys waiting for a hospital bed. And we know it's unsafe for people to come to emergency departments after triage and not being seen for many hours. So redefining common healthcare challenges around safety changes the whole dynamic.
Okay, and that's a very, I suppose, interesting and important part how do we integrate that into the reform? You also mentioned there, obviously, and Ronan, you touched on it, so maybe yourself and Rachel, with responsibility for workforce planning, listening to the workforce, and if people are saying, I don't feel trained, so I don't feel, fully enabled, I don't, we have training programs, so I don't from a policy perspective, and then run from looking at international research, how do we enable and support that workforce that is under pressure? So I suppose any thoughts and strategies and
there's
research on that.
It's great to kind of hear the focus about reframing and looking at how we do things, and then you can begin to think about the hard tools that we're so used to in terms of practice, and they're very important in terms of setting the scene and putting markers down for what good looks like. Because even when you go to culture and you think about, there's probably 6 different definitions of what culture is, even on this panel, but the one thing where we all share the common ground is we know when we're delivering or receiving care in an environment that has a good or a bad culture. We're all very clear on that, and it becomes... So I think the focus on the conversations, and something that Katie resonates with me, is there's an awful lot of good out there, and we are beginning to get better at talking about what good looks like. We understand what good feels like, so we need to harness what's working for our staff in these environments, listen to them when they find it easier to do their jobs, what makes them feel safe in practice, what patients are saying about their interactions with staff and what's making that happen. So our structures have to change to nurture those environments that are actually helping our staff to be able to respond the best that they can in what are really complex environments and sometimes very difficult situations. So I think that's what we need to be thinking about.
Roland, do you want to add to that in terms of...
Yeah, I think Rachel used the word complex, and I think increasingly there's recognition that the systems in which we try to improve care are inherently complex. And I think possibly over the last number of decades, we've approached patient safety from the perspective of saying, if we do this, then this will be the better outcome. Whereas I think increasingly we're realizing that actually, in many instances, because of the complexity in which we're dealing, we cannot predict what optimal will look like. And so I think increasingly we're going to have to focus much less on prescription of rules and specific behaviours, and instead focus much more on creating a culture of collaboration, of co-creation, of collective responsibility for decision making across a team. With digital transformation coming, I think we're going to have to completely redefine our traditional understanding of what a multidisciplinary team is, and I think we'll see creation of entirely new roles as part of those multidisciplinary teams that we haven't even conceived of yet. And I think it comes back to something that John said as well around the responding versus reacting and creating space. We need to create environments, and it's very difficult when there's so much pressure, but we need to create environments where space is given for innovation to materialise and come up from people who are tasked with delivering care. And I think as part of that, and Bernard alluded to this earlier, it comes to some of the wider commentary around the healthcare system. We have to accept that not everything we do in healthcare will be 100%. That doesn't mean that we don't strive for perfection. It doesn't mean that we don't seek continuous improvement. But if we're going to innovate, if we're going to change, if we're going to improve, then people have to be allowed to take a level of risk, albeit within guardrails and within boundaries. And so it has to be okay to fail, as long as that's within the context of continuous improvement.
Okay, and Katie, you wanted to come in on the co-creation, was it?
Well, I think Arun has had, talking about this concept of collaboration within a healthcare team. But my mother studied French back in the 50s, and she turned up to very few lectures. But one lecture she was at, the professor was saying, remember, this is teaching French. She said, remember the student is alive. Now, in this case, I think remember the patient can think. And actually, when we're talking about collaboration, I would like to collaborate in my own healthcare. And I think it's a really, really important, that here is a really strong missing link. If we recognise that the person most invested in their own healthcare is the person sitting in front of you, and they, however educated they may or may not be, that's something you, as a healthcare professional, need to establish, and that's back to health literacy. But more importantly, it's to recognise their investment in this. Also, the other thing we have to remember is that they're also anxious, and it's really well known in trauma studies and all that, the higher your level of anxiety, the lower your level of comprehension. But basically, at the bottom of all this is the patient's desire to get better, to collaborate in their own care. And I mean, we're moving away, we are, thanks to Jesus, moving from paternalism to a partnership. But I think that by actually recognising that part of the team is actually the patient or the patient advocate, you're winning.
Yeah, I think it's a very good point for any of us when we go as a patient. We feel that ourselves. So